Hello, everyone. I'm Michael McNutt with Weedy, and welcome to this Weedy Spotlight, Modernizing Medical Policy Management from Digitization to Questionnaires, sponsored and presented by Itiliti Health. Before we begin, some brief reminders. QA is done through the Zoom chat function on your Zoom toolbar, and slides and the event recording will be sent to all registrants post-event. It is now my pleasure to introduce the founder and CEO of Itiliti Health, Michael Lunzer.
Good morning or good afternoon, depending on your time zone. Welcome to another exciting presentation on the details of modernizing medical policy management, really heavily focusing in on the digitization of questionnaires. I'm the primary leader this morning, but I'm joined by Keith Brick. And Keith, I'd love for you to introduce yourself, and then we'll dive into the content for today.
Excellent. Happy to be here. I've been working for the past 15 years to promote adoption of FHIR and HL7 standards, and I'm happy to be our interoperability architect supporting the Da Vinci implementation guides.
Thank you, Keith. So just like to kick it off with a couple of notes about who Itiliti Health is, so you have a little context of where we're coming from. So Itiliti Health is a company that's very much focused on the prior authorization challenges. We started inside Blue Cross Blue Shield of Minnesota, building out some really exciting beginning steps of modernizing prior auth. Found that it was a really great platform and something that we wanted as an organization to share outside of Blue Cross Minnesota. So Itiliti Health was spun out into a separate company. Essentially what we do is we take in all of the rules and policy data of a health plan, digitize that information that's typically on spreadsheets and PDFs, and put it into a unified prior authorization platform that can answer all the questions about what requires a prior authorization, what the rules are about those down to the group level, as well as what to submit when a provider needs to submit a prior authorization. Of late, we have recently been very engaged with digitizing policies for multiple Blue Cross Blue Shield plans and others in the industry. Our products have been in the marketplace for about 5 years, so we have a real strong customer base using these solutions, and we'll talk more about those in just a second. So the particular products that Itiliti Health has, if you think about the spectrum from a provider writing an order all the way through a payer approving a prior authorization request. On the upper left, Itiliti Health has a policy management and content management application, which is really going to be the focus of today. And that's what helps the health plan codify policies, put them in a method that's easy for people to retrieve the right policy, but also generating the critical artifacts for interoperability with the new FHIR standards. Another product is PA Checkpoint, which helps to answer the question, does a particular procedure for a particular member require prior authorization? Another product is called Prior Authorization Routing, which helps to ensure that providers, when they submit a prior auth, it goes to the right destination. Then on the payer decision support side, we have automatic authorization rules that help payers make decisions automatically based upon the configured elements on the left side of the screen. And then Clinical Decision Assistant, which is an AI-based tool that streamlines the decisioning around those complex prior auths that have been submitted. In essence, this product suite helps to automate 80 to 90% of all prior authorizations for the health plan, and also supports all of the new prior authorization requirements that are in the market through CMS. We have, as I mentioned, a number of blue chip clients that have been using the Itiliti Health suite of services to support their call center when it comes to receiving faxes and interacting with providers. This same platform powers website tools and provider portal screens that essentially help answer, is an authorization required, allow a provider to see what's required to be submitted and actually submit a prior auth. And then now that same platform is being interfaced to the FHIR interfaces, which support the CMS 0057 requirements. So what we're going to talk about today is some critical questions that we get a lot from payers. Number one, we're going to talk just a little bit about how people do things today and why there are some critical needs and opportunities to change the way the way medical policies are managed. We're going to talk about why those policies need to become modular and more computable versus a large PDF document. We're going to talk about what actually CMS 00757 requires from payers when it comes to those policies. Specifically, how can a payer create these FHIR questionnaires that are a part of that requirement? What is the role of AI in this policy digitization process? How can it help? And where is it not appropriate? And then lastly, what does a successful policy digitization deployment look like? So that's the scope of our conversation today. And the first item we'd like to address is this high-level question of, why do we have to do anything different? What's wrong with what we have today? And essentially, the before picture of what health plans oftentimes have in place is spreadsheets or other rudimentary legacy systems that help to determine if a prior authorization is needed. Policies that are in PDF form that often have CPT codes that apply to those policies kind of buried within that Word or PDF document. Also, the criteria that apply to that policy are in text form and buried in that large document. And then when providers submit medical records, they're submitting them with multiple PDFs with no relevance specifically called out to how a medical record meets the requirements. And that relies on the health plan to perform all of that decisioning based upon a policy PDF and medical record PDFs. So how do we streamline this process and get to a point where there's more accurate transactions being exchanged between payers and providers? And so that's what CMS 0057 calls out, is really a series of transactions that are designed to document and detail the exchange of data that makes this process be able to happen automatically rather than all of the manual interactions that take place. There are three key transactions that are part of this 0057 requirement. The CRD, or coverage requirements discovery, helps to discover the prior auth requirement. Is it required? What policy applies? The DTR transaction communicates the information specifically that's required for the payer to make a decision, and that's delivered in the form of a questionnaire that goes over to the provider. And then lastly, of course, the actual submission or PAS transaction, which is when the provider submits that information and hopefully submits it in a way that makes it easier for the payer to make a decision, essentially matching up that patient information to the clinical criteria that's required. So when we talk about CMS 0057, to look at this in a picture, essentially what we have is this coverage requirements discovery that requires a prior authorization rules database. The next step in this process is providing data back to the payer about what is required and what data to submit, and that's that policy requirement database. And then lastly, submission that prior authorization system receive and the decision. All of those UM system health plan. We've entered product and health XPA management and clinic in picture. These of data provide an application in record system can provide systems also can
we are partnering with qualified health information networks to get that scalability. And by all of us speaking the same language, following these same implementation guides recommended under CMS 0057, we can make that connectivity a lot easier.
And those QHINs, as Keith described them, are part of the infrastructure in the middle of this diagram. Another piece of the infrastructure in the middle of this diagram that often kind of sits on the payer side is an interoperability server. Those are tools that help the provider, help the payer to centralize the communication between payers and providers on their side of the network, and also perform numerous value-added functions and critical functions for patient access API, payer-to-payer APIs, as well as surveilling and grabbing data from the transactions of CRD, DTR, and PASS to record that data for access in the patient access API and other communication tools. So if you think about what Itiliti Health's tools are here, is they are actually on the payer side, and they are sources of data, sources of truth that support those interfaces, connect to the interoperability servers, which connect to the QHIN, and ultimately then connect to the Epic or other EHR server or application. So today we're going to dive deeply into the policy management function and talk about what's required and what are some best practices for engaging and implementing this policy, documents, templates, and rules interface. So in essence, for DTR, what's required of a payer is to convert the guidelines that are within their policies into a application programming interface compliant DTR format. The term for that format is a FHIR questionnaire. Now, the guidelines that are within those policies are typically buried within those 10 pages. And when you think about it, those are the sections of a policy that have the ands and ors and words like one of the following or all of the following. That's the typical component of a medical policy that needs to be converted into a FHIR questionnaire. So let's talk just a little bit about the legacy of how policies are created and edited today. Most health plans, as we speak to them, have a work group that sits down and writes out medical policies, and they're typically using Microsoft Word. And they're redlining those policies and they're finalizing those internally. They're finally approved. And then at some point, somebody prints off that that Word document into a PDF or an HTML format, sends it over to the website team of the health plan, who deploys that policy into the website. And those policies, again, usually live as a 10 or 50-page document, which makes them really hard to quickly search and look for specific data. Some of the other really big challenges are versioning. So when a policy is changed and we edit that original source document, we send that over to the website team. They have to figure out a way to load this document into the document store on the public website that makes them easy to find, but also identifies the time frame for policies and when the new one overtakes the old one. And usually those website teams just replace the old version with the new version. They might keep a single archive version, but essentially it's really a flat document database. And that makes it really hard to manage those effective dates. This workgroup-oriented manual document process makes approvals and auditability really challenging because, again, the health plan needs to store and maintain all of the historical versions and the edits and the recommended changes that took place. So maintaining that history becomes a very manual and file-intensive process, which makes it really inefficient to administer, and again, really hard on the website to develop a simple way for website users to find policies. And now with the new requirements, these policies need to be able to be exposed as elements of a questionnaire, and it needs to be really easy for technology to find the right questionnaire. So we need to add versioning and date-driven parameters to these policies. One way that organizations have been talking about meeting this compliance requirement is essentially taking this PDF document at the final tail end of this process, putting that PDF document into an AI tool and asking that AI tool to generate a fire questionnaire that matches the PDF. One of the big challenges with this type of a process is the health plans have spent years validating and creating these very critical criteria that are evidence-based. There's a high risk that AI changes the meaning and the detail of that questionnaire or that criteria to where it's not exactly matching the original source data. And that becomes a really big challenge. Now the health plan needs some way to compare the criteria versus the fire questionnaire, which may be significantly changed. And that makes it really difficult for anybody to quickly validate those questionnaires. Another thing that's really important, again, is that we have these fire questionnaires in some kind of a database that's date-driven that also has associated procedure code rules. All of those things are not really well accounted for in a straight fire conversion using AI. And then, of course, we get into the retrieval process, which gets even more challenging. And what we've learned is health plans are looking for a very detailed, repeatable, auditable process that clearly matches the content and the criteria of the original source policy.
And so to be explicit about that, our goal is to provide you an idempotent, a reliable, consistent, always produces the same outcome algorithm that helps you write those policies in a way that can be easily converted into computable language. And that computable language can be supported by the EHR or whatever system the provider is using to fill out those questionnaires and submit the required information to you for prior authorization. So in general, our goal with the policy management module overall is to not only help you clarify the language in your policies, but as Michael mentioned, extract the procedure codes and the criteria that make that policy relevant to a provider submission. If we think back to the workflow, our provider is placing an order and they know that the patient has a given piece of insurance. Our job with these APIs is to say, great, based on the order that you've placed and based on that patient's plan and group, here's the information that you'll need to submit. That's all there is to it. But doing that with an API requires that we have well-structured policies. And we want those human readable policies on the website to be exactly what the digital policy that the EHR and the APIs are using. We need them to be in sync because any sort of mismatch is going to mean that what information the provider gives you doesn't match up with what the prior authorization requires. So in our platform, when you publish a policy and you have its linked to questionnaires, that is immediately reflected on the websites that draw from our backend and immediately reflected in the APIs that use your questionnaires, use these policies. And as Michael mentioned, those policies are often published in advance. So we'll say 45 days out, the policy will change and we'll have new criteria. And we can publish that with an effective date so that when the doctor places an order, if that order is for tomorrow, you'll get a different answer than if that order is for 60 days from now. Anything else you want me to add there, Michael?
No, that's excellent, Keith. The one thing that I think is really important to keep in mind is that this is kind of a triple win. Number one, we create a very efficient process for the creation and the modification of policies for that policy management team. So they gain dramatic efficiencies in their world. There's also added data to these policies. So now we have that effective date and that approval process. And now the human readable policies, instead of coming from a flat database, they can come directly from this system. So instead of sending a policy over to the website designer who loads up the policy into a data store, the website takes their policies directly from this tool. So that means that the website never has to do anything new. The policy management team creates a new version, saves that with an effective date, and when that effective date is appropriately retrieved from the website, that's the policy that shows. And then, of course, as we've spoken a lot about, we generate that questionnaire. And that's the part that we'd like to talk more in depth about next. So just a little deeper perspective on the DTR requirement. We talked about a questionnaire. So what is a questionnaire? I think a lot of people, when they think about a questionnaire, they think about somebody asking them, what is the BMI of the patient, or does the patient have this particular condition? But there's all kinds of different ways those questions can be formulated within a FHIR questionnaire. It can be a yes/no question. It can be a text entry question. It can be a clinical measurement question, or it can be as simple as asking the provider to attach a particular document. So it's not like Jeopardy, where we're asking everything to be in a certain format. It's the critical objective of getting that data that's necessary to make a decision from the provider.
And I want to add there that many of these questions can be answered by data that is in the EHR. And if we structure our question correctly and we include the codes, for example, if we want a history and physical, or if we want a surgical note, we don't have to ask a provider or their administrative staff to manually attach that information. We can instead instruct the EHR to retrieve that document and make it part of the submission. Then when the prior authorization coordinator is seeing that questionnaire, they'll see, all right, this document has already been pulled in because it matches the LOINC code on it, matches exactly what the questionnaire is seeking. This saves a ton of time for both the provider and their team as they're filling it out. And also on your side, this is exactly the document. It's not part of a 50-page submission. It's this precise document, this clinical note is where the provider documented that justification or that piece of information that you need.
Another companion element to the questionnaire is that deeply within the questionnaire logic, the payer is configuring the optimum answer, or the various permutations of answers that can generate an approval. So if the provider answers all of the questions appropriately, they can know ahead of time, and you can know immediately that their answers meet the requirements. Now, as we talked about, it would be wonderful if every questionnaire, every policy, every procedure that you have has a very thorough, detailed questionnaire. Now, as you might imagine, there's a little bit of work in making sure that you've completely defined all of the criteria into a very well-structured questionnaire. The important thing is there are alternatives in the interim as you're working on these questionnaires to get them to a fully codified, automated structure. These questionnaires can be as simple as just asking the provider to attach documents and facilitating that function inside of the EMR. And now we're just going to talk a little bit about the process of creating a questionnaire. So within the Itiliti Health application, this is an example of the original criteria. So what Itiliti does is we ingest all of the health plan's policies. We automatically deconstruct that policy into its appropriate buckets of information. One of those categories of information are the decision criteria that are somewhere in that policy. That decision criteria is then ingested into what we call Criteria Builder, which is a tool that shows the user the original policy criteria on the left side of the screen. That same Criteria Builder tool has intelligence that has the ability to essentially read the operating conditions within a policy and can identify procedure codes and other entities. And so it automatically converts the human readable version that you've been working with forever into a FHIR compliant version of a questionnaire. And so if while I'm looking at this Fire version of a questionnaire, I start to answer the questions, it's actually a live questionnaire. So as a user who's gone into this application and ingested their policy, I've got the criteria that were human readable and the original criteria on the left side, and that new automatically created Fire questionnaire on the right side. I can start to click through and answer questions, and the system will tell me, based upon those answers, how this response will be automated. So it's an extremely powerful tool that allows you to quickly create these questionnaires. And again, I'll show you in a minute how these questionnaires are again tied to the original criteria, which is a part of the entire policy.
I want to add, while we're on that view, uh, you might notice that some of these questions could correspond to data that was in the CRD request. And that's the very powerful benefit of this workflow in an API-driven world, is that if a doctor placed an order for 33418, we no longer need the provider or their staff to tick that box. We can pull that information and tick that box here in the questionnaire, saving them time. And as we think about this electronic form, what we're trying to do is replace that piece of paper that today says, when you submit a prior authorization, these are all the things that you need to fill out manually. Our goal is to replace that with things that, as much as possible, can be answered by data in the EHR.
One of the really important attributes of the Itiliti health system is that we are not changing words from the left side to the right side of this equation. And that's really important, because if we were using a pure AI approach and pointing AI at the criteria and saying, give me a questionnaire that matches, that gets to the same answers, the AI tool may actually change the text. And that can make it more difficult for a clinical reviewer who's validating that the tool has accurately represented the information on the criteria that, again, has been built over years. It's really important that this data from the left side be identical to the data on the right, and that the meaning of this is well preserved. So our tool is built in such a way that we are not using AI to transform words. We're just recognizing the operators and representing those operations on the right side. So that makes the validation and the actual quality control of this transition easier and more effective. Once this has been completed, the actual product of this is a Fire version of that questionnaire. This Fire language, this codified, coded language of the questionnaire, is actually what Itiliti Health is reading when we're presenting the right side of this. So behind the scenes, Itiliti's tools have converted this text into that Fire language and then represented or read that Fire language on the right side of the screen. The right side of the screen, again, reading that Fire information, is identical to what the provider would see, because the workflow is going to be that the provider in their EMR is going to request to submit a prior authorization. They are going to be sent, their system is going to be sent this code. From there, their system is going to read that standardized code, and it's going to represent that code exactly as you see on the right side. That's the benefit of this standardized approach. Anything to add there, Keith?
I think you've got it exactly right. The standardization of the implementation guide says that everybody, EHRs and payers, are going to speak the same language. We're going to use this JSON structure to represent the criteria that we need the provider to fill in. And so that allows us to have parity. We no longer need to have 16 different web portals for a provider to log into and submit data to and upload attachments to. All of this can be done natively within their EHR.
So I'd like to talk just a little bit, have Keith talk a little bit about more of the detail of this DTR. And what this will help illustrate is that, again, having just the fire questionnaire capability, the ability to have this fire code in a system, is not enough to comply with this DTR requirement. This data in this fire questionnaire needs to be associated to a number of other pieces of information. And Keith, I'd love you to talk through the workflow and
Sure.
the anatomy of these transactions.
Yeah. So in the very first step, the provider placed an order. Let's say Keith needs shoulder surgery. In the background, the EHR is composing a CRD request. That CRD request goes over to the patient's health plan and hears back, yes, you will need to submit a prior authorization for that surgery. The questionnaire is available to you at this URL. The EHR then says, okay, the provider's moving forward with this workflow. Let's go get that questionnaire. And so that's the little arrow to the right here in the middle. And it reaches out to the, in our case, our DTR service and says, Keith, with his coverage, needs shoulder surgery. What questionnaire do I pull back? And in the response, you see that JSON that Michael was sharing earlier, and now the EHR can render that and show it to the provider. As we mentioned, the elements of that questionnaire can be bound to data in the EHR, so certain things can be filled out automatically. Only the remaining questions, things that require provider intervention or the help of their staff, will be there for the provider's team to fill out. And importantly, each step of the way, we have traceability and auditability so that if the provider gets all the way to the claims step and they're wondering, well, how do we know we have the right prior authorization for this patient? Both the EHR and the payer systems in Itiliti Health have the tracking numbers that are linked to each step of this workflow. So in that DTR request from the provider, they're saying, I'm going to get that form. Here's all of the information that we need in order to pull back the right form. There's one other thing that I forgot to mention with the CRD, which is that the EHR, when it composes that CRD request, also includes a fire authorization. This allows your system on the payer side to reach out to the EHR to pull additional information. For example, if in order to authorize the shoulder surgery, we need to check if Keith has had a shoulder MRI, you can go and find whether that is part of Keith's medical record using the fire authorization that was included in the CRD. But in general, these are the data elements that we need in order to find the right form. And then in our response, we're going to send back a bundle of questionnaires. So we can have one or more policies that apply to a given procedure. And each of those policies has its broken down digital elements that we need the EHR to satisfy. And as much as possible, our goal is to help you, the payers, link those policies and those data elements to value sets, things that are coded in the EHR world. So for example, when the doctor records my height, weight, blood pressure, all of those things are recorded and linked to the LOINC codes that are the international standard for what what code represents each of those data elements in the patient's chart. And with extensions, we can do things like execute clinical query language or CQL. This allows us to perform a complicated search. For example, has Keith had an MRI in the last 90 days is a question that we can ask with CQL that the EHR can then answer without the provider having to go and dig through the patient's chart and find that answer. So the next step, prior authorization submission. The provider has placed an order. We've told them they need a prior auth. They've asked for the questionnaire. We've given them the form to fill out. The EHR has helped them fill out that form, and now they're going to submit it all together as a bundle. That submission includes the patient information, who's ordering it. Now, at the time of submission, we know who's going to be performing it and where it will be performed. We've selected our specific procedure code that will represent the treatment that we're performing for the patient. And we have the member demographics and the coverage information that allows us to know, yes, we're still talking about the same patient with the same insurance. We've also, in that bundle, got the questionnaire responses, all the answers to the questions, and any attachments or fire resources that were pulled by the EHR or attached manually by the provider and their staff. All of that together is in one JSON bundle that we can then ingest and compare against those automatic authorization rules. Michael mentioned when we were looking at the policy breakdown that there are certain combinations of criteria that we know immediately qualify a patient for a given procedure. For example, if we have a GI procedure, a gastric bypass, and the patient is over a certain BMI, we might immediately choose to authorize that without needing to review anything else in the patient's chart. And that's an example where we have been able to save a tremendous amount of time for the payers that are using our products and platforms. And it's important that under CMS 0057, you have these capabilities to respond immediately because you have a requirement now to respond within 7 days, or for a high criticality case, respond within 3 days for these prior authorization requests. I say now that policy will become effective rule as of January 1st in 2026, and will take effect. The requirements will be enforced as of January 1st, 2027. So we've got 14 months to help all of you build these policies and get them in place so that you can respond very quickly when the provider provides all this information to you electronically. They need to get back an electronic response that says, yes, Keith is approved. You can go ahead and schedule Keith's shoulder surgery.
So one of the things that we really wanted to make sure we illustrated with this deeper dive into these transactions is the idea that when the provider is requesting the right questionnaire, the responding system needs to be able to navigate all of the reference data about the patient to be able to determine what is the right questionnaire. So it's not as simple as just creating those questionnaires and associating them to a policy. We also need to then take those policies and ensure that they have coded reference data and rules that can help us ensure that we retrieve the right questionnaire based upon the date of service and all of the other attributes.
That's
And
actually a
that's
really good point. Sorry, Michael. I had a personal experience with this where my particular plan had a carve out that included a benefit that did not apply for other plans within that payer. And so one of the things that we do in our policy management system is link the policy to the plan group and business line so that we can support getting that right form back. I had the problem where I called the call center, member services said, well, this policy applies. And I had to point them to my 100-page policy document to say, actually, my version of your policy has a carve out where that doesn't apply. And we are able to represent that electronically so that when those questionnaires, when those forms come back to the providers, they're getting exactly the right one. Sorry, Michael, back to you.
no, that's a really important point. And again, it's why Itiliti Health is taking the data that's buried in spreadsheets and PDFs, such as code associations to policies, carve outs for specific groups, which version applies on which date of service, all of that information, we're breaking that out into data that's active versus spreadsheets and PDFs. One example of what we hear happens often is that when the call center is asked, does something require a prior authorization? They have a hard time answering it. And in fact, somebody recently did an exercise where they called call centers and oftentimes they got the wrong answer. They called them for the same procedure, the same patient, the same date of service multiple times over a period of time and got different answers from different call center personnel. And that's because, again, this data is buried in PDFs and spreadsheets and hard to retrieve. So by unifying all of this data into an effective system, you're making the business operate more efficiently, saving money from providers not having to submit prior auths for things that don't actually require them, submitting prior auths with the right information, and actively being able to access the right information for each patient. Couple of key elements that I want to just kind of illustrate in the Itiliti Health application. So for instance, this is a screen that shows a particular policy, and that policy has a version A and a version B. So version A is published, and that one's going to be effective from now till December 31st. And the new draft policy is going to become effective January 1st, 2027. So once these are both authorized and approved, if somebody was to ask what the policy was for December 30th, they would get version A. And if they asked for January 2nd, they would get version B automatically through the interactive interfaces and APIs. Again, similarly, if they asked for that information on the website and they said, I want to see the policy for December 20th, they would get the combination of all of this information in a human readable form, just as it looks today on your public website. We reconstitute all of these elements into a human readable version that looks identical to the version you have today. If, on the other hand, it was the CRD or DTR transaction that was asking for this information, then the system would know to go in and pull the questionnaire content and submit that back for the DTR, for example. All of this information and that version is also associated to the procedure code rules. So you see here that we've got a procedure code associated to that policy that's also associated to the rule for that policy. And I have the beach ball of death here. I'm hoping that that will stop in a moment. We're close to the end of the presentation, but I might have to restart that. Whoops, there we go.
There it goes. We got
It did let me go. Okay. So that's the essence of the system. And the next item I'd like to talk through is, what does it look like to actually implement this process? So before I do that, Keith, is there anything you'd add before I kind of go through the last three slides, which kind of cover a use case experience?
I think the most important part is that when somebody is logging onto the website, whether it's a patient wanting to know what are the prior authorization requirements for something the doctor told them they might need, or the provider trying to get that patient scheduled and using that information. Today, they're logging onto your website, they're typing in a search term and hoping to find the right document. They might get 100 matches. They need to then dig through them until they find the one with the right effective date. With this system, we give them exactly the right information that's relevant, and it's traceable so that when they get that answer, it's not he said, she said over the phone. It is a transaction ID that says this policy was referenced and this is how we matched it. This is why this rule applies. And that's a huge benefit. It reduces risk, it reduces cost, and it reduces the mistakes and delays in patient care. And so that's why I'm so passionate about it.
That's great, Keith. So again, just to talk through, what does it look like for a health plan to go through this experience? So this is a real client. They had over 600 medical policies. They had a couple different formats. Some of them were in Word, some of them were in PDF. The first phase is to ingest the policy itself with all of the various components of it into the system and essentially deconstruct them into those various buckets that I showed you on the last slide. At that point, the health plan can look at what does a policy look like before it came into Itiliti Health, and what does the reconstituted or regenerated policy from all of those different buckets, when we want to see the human readable form, does it look identical to the before picture? And it should. And that's a user acceptance phase. The next step of the process is to look at the questionnaires that are automatically generated from within each policy. And that's a process where the clinical users look at the side by side, as I showed you earlier, of the criteria on the left and the actual questionnaire on the right, and make sure that it matches the logic that it should from what the original criteria was. This entire process from start to finish is typically around 3 months. And once that process is complete, again, we've got 600 policies fully digitized. We've got a human readable policy that can be accessible in a public website with multiple search parameters that can be applied to find just the right policy. And we've got a companion DTR questionnaire that's integrated into the CMS 0057 process that again retrieves a married or a companion questionnaire that's already been validated and compared to that human readable version. If the health plan wants to make adjustments to those policies, they can clone an existing policy, edit the policy, propose that edit to the clinical review staff who can review it. And once they've approved it, it's automatically available on the outside access points of human and DTR access. So to kind of recap, some of the critical things that come from this transformation of policies into questionnaires is at the top of this list, of course, is compliance with CMS 0057 and the DTR capabilities that are necessary. But in addition to that, there's tremendous benefit that comes from this conversion process. Specifically getting to a point where policies can be easily searched by policy number, keyword, many different elements. And those elements can be assigned, the policies can be assigned to each line of business. There can be variations by line of business. The CPT codes that apply to different business lines can be recognized within the system. We'd love to have an opportunity to demonstrate the system live. We can show you all of this capability in a live demo. If you reach out to us, we'd be happy to schedule that. Reporting and auditability. Again, when changes are made in policies, those changes are tracked, who made them, when they were approved. And then we can also distinguish between active and past dated policies. And that's also helpful for claims management. If there's a denied claim that's been requested to be reviewed, it's easy to go back in history and find the specific policy that applied. Again, by line of business, all policies are there. And of course, we have version control so that we have a very clear audit process. So with that, I'd love to open it up for questions. Again, we would love for you to reach out and invite us to perform a demonstration and get a little deeper into your specific areas. I do see a question about policies regarding state policies. There's a number of state rules around regular review of policies and review dates and tracking all of that metadata about each policy. Those are things that are clearly tracked in the Itiliti health system. All of the history and the necessary compliance are elements that are part of this system. Another element that's really important, though, is we get into situations where the state has their own provider manual. And typically those criteria and policies are kind of buried in that state provider manual. We have certain states that are currently working with us to look at converting their provider manuals into the Itiliti health system to give them a more trackable and manageable process that is DTR compliant. In other cases, we have payers that are ingesting state provider manuals and creating their own policies from those provider manuals. Either approach is possible with this Itiliti health system. So Keith, I don't know, you usually do a great job looking at the questions.
Yeah.
You want to grab some and answer those as well?
So the first question from Chad is about the need to update policies at least annually. And so I know one of the tools that we have to help do that is our change management dashboards, which show you the policies and their effective dates and their review dates. And so what you would do is you would, based on that review date, know that policies that are approaching 12 months are due for review by your clinical team. You'd need to publish a new version of it. From Dave, today we zoomed in on DTR because we've had an opportunity in the past to talk about CRD, and in the future we'll probably talk more about prior authorization submission. But yes, Itiliti Health provides your CRD, DTR, and PAS endpoints, as well as the subscription API that is necessary for a provider to listen for updates. So for example, they've submitted it. It's one of those cases where you need a human clinical reviewer on the payer side, and so it'll be in a pending status. Once that decision has been made, then the provider can be notified if they've subscribed, or if they haven't subscribed, what they'll do is they'll call back in to that prior authorization endpoint with $inquire and say, hey, is this prior authorization approved yet? And then that's where we'll provide the updated response. And Dave asked about QHINs, and in general, our incoming requests are routed with the payment exchange purpose. There are scenarios where you would use either payment or healthcare operations. There's a longer discussion to be had there, but for the most part, when we are dealing with inbound CRD requests, we're not having to go out to the network and make a broadcast query, so we don't need to attest to a specific exchange purpose. We're just receiving information that's been routed to us. And I think, Michael, would you like to speak to the expansion into the prescription and PBM capabilities that we have coming
Yeah,
up?
that's a really exciting topic. CMS has recently made it clear that the 0057 prior auth APIs will be required to support the pharmacy in the retail pharmacy area. Today, Itiliti Health's applications are currently used for specialty pharma, and Itiliti Health is definitely intending to support the full pharmacy related capabilities as well. So we'll be excited to see what's coming from CMS there and when those requirements are out. But for right now, again, Itiliti Health is working with specialty pharma and is in the process of making that transition to retail pharma as well.
And from Juan, we have a question about, have we implemented or worked with any delegates? And do we have any concerns about supporting those vendors? Would the lift be just as heavy as implementing with a health plan? I think what you're asking is about the delegated vendors. For example, Carillon, or let's say a subset of your policies are managed by a third party. Yes, we absolutely support that. It's part of our implementation is to understand which of your policies have rules that are decided internally within the payer organization, and which of your policies consult external sources of truth for prior authorization requirements and prior authorization decision making. Juan, if you want to ask
Yeah.
from the vendor side. Michael, do you want to speak more to that?
Yeah, I'd like to talk just a little more about it. So this is a really high level map of kind of the entities in the process. So if you think about the Itiliti Health prior auth database, it's the source of truth about what requires a prior authorization and where is that prior authorization going to be determined. So it might be a scenario where we say, yes, a prior auth is required. That's going to be handled by Carillon. And when we respond back through that CRD request, we can tell the provider that next destination to get that DTR request or that DTR questionnaire. We can give them our destination for the DTR, and then we can proxy the delegated vendor behind us. Or in this CRD source of truth response, we can tell the provider, yes, this requires a prior auth. Here's the URL to get to Carillon. So there's a couple different ways that can be architected, but ultimately that routing information is easily managed through the Itiliti Health system. We haven't spoken much about this, but our tools are a software as a service based application. So when we implement a client, we help you get all of your data and systems set up correctly. And then we kind of turn over the keys to managing this data. It's a web-based interface. It's easy to manage and easy to work with. For that first period of time, we kind of hold your hand. The first week, if you have changes you want to make, we might make them for you and have you watch us. And once you've been live for a little while and you're confident, you might make the changes and we might watch you. And at some point, we take the training wheels off and you can go ahead and make changes as appropriate. So all of these rules, for instance, of which procedure codes for which lines of business and which groups are delegated to another vendor or which procedure codes are going to be managed by a policy you own. Those are all rules that are configured in the system and help to manage that routing. The routing itself when a prior auth request comes in, can again either be proxied by Itiliti Health, or the routing can occur inside of a fire server, such as OneUp Health or Onyx or InterSystems. So those types of fire servers are a part of this experience. But again, we are the source of data for those interactions. And this is one of the elements that I think is very confusing sometimes to people, because they may have procured a fire server to support their patient access API or their payer-to-payer API, and that fire server company may say, we support CRD, DTR, and PASS. And really what those companies are saying when they say they support those transactions is that those transactions can flow through the fire server and can access your source of truth. Most health plans do not have a source of truth that is CRD ready or DTR ready. So that's where there's this really great marriage of a fire server alongside an Itiliti Health CRD or DTR solution. And then lastly, of course, pass, when that prior auth has come in, that submission has come in, that pass transaction can be handled by the Itiliti Health auto auth rules system, and then interactively passed over to the system, which performs its normal role of notifications and internal workflow, etc. Any other questions?
We've got 4 minutes left. Feel free to come off of mute or drop a message in chat and we'll get to you as quickly as we can. I wanted to share an example while we're here that the fire server can support a workflow that is really important when a provider places an order and the information that the payer needs isn't in the provider's EHR, but is perhaps already in the data that the payer has collected. And in that scenario, the questionnaire can have answers filled out, not just by the provider EHR, but by your own internal fire server or the networked resources that you are able to internally map to. And that's really effective, especially when, for example, in my case where I need a shoulder surgery, the payer needs to know, has Keith had an MRI in the last 90 days? Well, the payer already knows, they paid for it a month ago. And so that information is in your fire server.
I think there was a question about, from a vendor perspective, how does this information fit in? And I can help clarify that. So the CRD, or is auth required database, is again that source of truth for whether or not a prior authorization is required. That data is not really relevant to a patient, it's relevant to a group or rules about a patient. And so that information doesn't have to reside or even touch the utilization management system. Once a prior authorization is requested, or the provider wants to submit a prior authorization, again, that DTR that questionnaire is sent directly to the EMR. It doesn't have to go through the system. Of course, when a prior authorization is submitted, then that prior auth needs to get into the system, which is the source of tracking and workflow and prior auth numbers, etc. So for instance, when that prior auth comes in, if the rules say that this particular submitted questionnaire means that the provider should get an immediate approval for that prior auth, the auto auth rules can be configured to automatically send back that approval via FHIR and notify the system that a pre-approved prior auth has been submitted, and the system goes on and submits the appropriate responses with letters and tracks the response, etc. Or the auto auth rules can first send that prior authorization to the system and say, here's a pre-approved prior authorization, get a prior auth number, and then route that PAS response back to the EHR. One last point I'd like to make in this, and I'll ask Keith to jump in.
Got 1 minute left.
All of these activities look like a lot of interaction. And the perception could be that, wow, I'm going through all these different data points. How long do these things take? The best way to think about this is web technology. So all of these queries, all of these activities are real time, just as you see with a browser when you sign into a website and you ask for specific information. All of these transactions are real time, no matter how many of these bounces or movements you take between different systems. All of this stuff takes place in near real time or similar to a typical web query.
Yep.
Keith, last comments?
Just one other cool thing is that during the CRD workflow, it is also possible to say, based on the information you submitted in your original request, as soon as you place the order, you can get back a prior authorization number. And that is really powerful. It is a great accelerator for getting patients treated faster. And I'd love to talk more about that in a future session. Thank you so much.
And I guess one last point, because Anna posted a note. We forgot to mention that we just recently issued a press release that's very exciting. We've had a large payer that has gone live with all three of the prior auth APIs at scale. So CRD, DTR, and PASS are being used in that environment and fully operational, accepting, processing transactions in real time. So it's a really exciting development for Itiliti Health. We'd love to give you a deeper demo of our systems and really appreciate your time today and look forward to hearing from you all. Thank you.
Thank you so much. Michael Lunzer, Keith Brick with Itiliti Health. Thank you once again for offering your expertise and sponsoring the spotlight. As mentioned earlier, recordings and slides will be sent to all registrants post-event. Please visit wedi.org, wedi.org, and check out our event calendar for upcoming educational offerings, including our national conference, which will continue to cover 0057 implementation, along with several other key topics in health IT. We'll be there. Itiliti Health will be there, and we hope to see you there as well. Once again, visit wedi.org and visit the event calendar. Thank you once again. Enjoy the rest of your day.